Okay. Let me just introduce our presenter for today. It is our privilege, a great honor to be graced by one of our guru in ultrasound in Zimbabwe, one of our senior lecturers in medical ultrasound, Dr. Josephine Tityiwe. Dr. Josephine Tityiwe is a senior lecturer at the National University of Science and Technology. She's also the program coordinator for MSc Medical Ultrasound. To all those that have enrolled at the National University of Science and Technology in Zimbabwe, we all know our very own Dr. Josephine Tityiwe. She also hold a PhD in diagnostic imaging ultrasound from the University of Salford, United Kingdom. She also has a master's in radiography from the University of Salford as well as other qualifications attached. So help me welcome tonight our presenter, Dr. Josephine Tityiwe, who is going to be taking us through the role of ultrasound in renal dialysis. Dr. Tityiwe, it is a great honor to have you here. We're going to hand over this time to you. Over to you, Dr. Tityiwe.
Thank you very much, Chinese. Thank you very much to Tawera and all the team members for Radiology Without Borders. I greet you. I greet all radiographers and sonographers, radiologists within Zimbabwe, beyond borders. Thank you very much. It is my honor to be given this chance to be presenting on this platform. For us to be cruising well with network, I shall be switching off my video now that you have seen me. Thank you very much. I hope you are hearing me well. Kindly indicate if you are not hearing me properly. All right. So now that... Hello? Okay. So now that I've switched off my video, my title that I'm zeroing on is Role of Ultrasound in Renal Dialysis. Thank you very much. Forgive me, seems my PowerPoint is ticking. 1 minute for me, please. Okay, so I think you've already heard about me, so I should be starting now, all right? All right, so this is my resume. Okay, I just want to remove this. There's 1 minute. Yeah, okay, I think we are right now. All right, so we are starting. So before we talk much about the topic at hand, I thought I would need to take you through a little bit of anatomy so that we are cruising together about what we are talking about. So it's about the urinary system. So in this image, I'm not sure if you can see my laser pointer. Let me try to put a laser pointer for you. Okay, so in this my overall image, we are seeing the urinary system, which is consisting of 2 kidneys, these 2 bean-shaped organs, and superiorly to each kidney, we've got what we call the adrenals. We also see the innervation of the blood of the vascular system that innervates the kidneys. In blue, this is the venous. So the main vessel here is the inferior vena cava, and we have the renal veins, right? And then in red is the abdominal aorta, and in red we've got the 2 renal arteries, right? So you know obviously that the right kidney is lower than the left, or because the liver is bigger, and to the left you only have got the spleen. So anatomically the right kidney is lower. So the main job or main function of kidneys is to filter blood plasma of our waste products from the respiring cells of our bodies. And when they filter all the waste products and excess water, it is drained out of the kidneys into these 2 tubes, which we call the ureters, down into the bladder. The bladder is the reservoir for urine, so that voluntarily at certain times it can be voided. Okay, so okay, so now the gross anatomy of the kidneys, like I said, so the kidney is composed of lobules. So within the main kidney that you saw on my main anatomical picture, inside are several lobules inside each kidney, and each lobule, it consists of a rim of cortex that's surrounding a single medullary pyramid. And then this pyramid is the one that terminates in a papilla protruding into a minor calyx. And the cortex forms a rim that envelopes the medulla, which takes the form of regularly spaced pyramids. So for us to say medulla, we are seeing several pyramids that are located within it, forming that layer. And then the pyramids end in the papilla that jut into the minor calyces, and these later on join to form major calyces. So the major calyces coalesce into the central renal pelvis and finally into the ureters. And then in between the various dotted pyramids, in between them, we've got what is called the column of Betting, which fills in the spaces between the pyramids. So if we look at this anatomical diagram, if you can see my laser cursor, so with this, our kidney, the outer part, we do have the fascia. From the fascia, we've got the renal capsule. And then from the renal capsule, the first layer that we are having here, according to my pointer, this is the cortex, okay? The cortex of the kidney. And in the dark little structures, these are what we call the pyramids, right? And in between the pyramids, we've got the renal columns or the columns of Betting. Okay, so you can find out that each renal pyramid is coming down, it's narrowing like a little funnel. So where it narrows like a little funnel is what we call the papilla. And the papilla now gets into the first part of the calyces, which is the minor calyx. And the minor calyces join the major calyces, and now we have got the renal pelvis in the middle. So it means all these minor calyces will be draining into their own major calyces and into the renal pelvis, and finally down into the ureter. Okay. So now the blood flow, now because I said the job of the kidneys is to filter blood plasma. So blood comes from the abdominal aorta, right? From the heart, abdominal aorta, that is the left side of the heart. We know that the left side of the heart is containing blood, which contains oxygen because it's coming from the lungs. Okay, so it comes down the abdominal aorta of the heart, branches into the 2 renal arteries, from the 2 renal arteries into the segmental arteries. The segmental arteries are the first branches that are innervating the main segment of the kidney. And then from the segmental arteries, it goes into the interlobar arteries. These are the arteries that are now perfusing through the various lobes. All right, I said one lobe consists of a part of a cortex, a pyramid, and a papilla. So around them, and then also continuing distally around these lobes, we've got what we call arcuate arteries. And from the arcuate arteries, now we've got the cortical radiate arteries. These are now the ones that are perfusing the cortex layer of the kidney. Now, from these cortical radiate arteries, we've got the afferent arterioles. The afferent arterioles are the ones that now link to the glomerulus or to glomerular capillaries. You'll find out more as I continue to explain that the glomerulus is the apparatus that does the filtration inside the kidney. So the afferent arteriole interface into the glomerular capillaries, which now enter and become the apparatus for filtration. Now, from there, when the filtration is done, the blood that is clean is leaving the apparatus through the efferent arterioles and now join the peritubular capillaries and now into cortical radiate veins, arcuate veins, right? Interlobar veins, and to the renal vein, right? So now, this is the innervation of the renal system. And the renal vein is joining what? The inferior vena cava, now going to the right side of the heart. Okay, all right. So now, this is what I'm talking about. This is the renal artery coming in with blood containing oxygen and nutrition as well. But as this blood is coming, it also gets sieved of all the rubbish. And then it's now leaving here through the renal vein. All right. So this is what I was talking about. From the renal artery, we've got the segmental arteries. You see them. And we've got the interlobar, arcuate arteries, cortical radiate, and then we've got the afferent arterioles, which now innervate into the apparatus for the glomerulus. Okay. Right. So again, another small image for you to understand. This is the apparatus that I'm talking about, right? So this is what we call the glomerulus or the renal corpuscle. So what we have is the afferent arteriole will come with the blood and it innervates within the glomerular capillaries. Here, these capillaries are having some fenestrations within them. And within these fenestrations, what is not wanted from the blood is sieved into this corpuscle or into this glomerular capsule. And then it continues within these tubules. So what has been sieved, what remains in the capillaries is what is wanted, right? But to find out that these capillaries will continue, they will be winding around this whole tubule, out until. So as they are winding up, we still have the process of some constituencies are secreted into the tubules, some back, until we maintain a homeostatic balance. And then these capillaries will become what? The efferent capillaries to be leaving the apparatus. Okay, now since we are radiographers and sonographers, we also need to be familiar with the sonographic anatomy of the kidney. This is what we see when we are performing ultrasound. Now, this is the renal pelvis. The white part of the kidney, it is called the sinus. Or why it is white? It is because it consists of the fibrofatty material, which tends to absorb or to attenuate more of the sound beam. That's why it is hyperechoic, right? So this is the hyperechoic region. So now, sonographically, again, the outer part of the kidney, this one is our cortex, right? That's our capsule in the outermost part. This is the cortex, right? And the medullary pyramids are the little dots which are black, right? The little dots which are black. So the little dots which are black are the medullary pyramids, and the papilla is towards the end, which means at the end is the minor calyx, and the major calyx are just within the white part of the sinuses, and it comes to the renal pelvis. So which means this part we only are able to see it on sonar if there's a blockage that is happening, maybe here distally, and we've got an accumulation of urine in the proximal ureter, in the pelvis, major calyx to minor calyxes. So this is the sonographic anatomy that we see when we are scanning the kidneys. Okay, now the topic I've been given, it is what? Renal dialysis. But now, for me, before I start to talk about renal dialysis, we need to know the reason why an individual will need to have dialysis, right? So for you, when your kidneys are normal, like what I've shown you before, in the previous slides, there's no problem at all. But now come a time when your kidneys are diseased, or what you call nephropathy. Nephropathy is just disease of the kidneys, right? And now you find out that various conditions will result in nephropathy. And what nephropathy does to your kidneys is that for you to say these kidneys are having nephropathy, the kidney would have experienced what you call cortical atrophy. Yeah, so the disease makes the kidney to experience cortical atrophy, or the disease makes the kidney to experience what you call papillary necrosis. So now, as sonographers, what we are now interpreting on the monitor is now aspects of cortical atrophy, which may manifest as reduction in the length of the kidney, the size of the kidney. We see some lobulations within the, when you are tracing the outline of the kidney, or we can, and also the kidney will change its echo pattern or echo texture. And also papillary necrosis, which may make the kidney to change its echo pattern or result in small blockages that start to manifest within the minor calyces of the kidney. All right. So the natural history of many renal diseases converges on a common pathological picture of cortical atrophy and papillary necrosis. And these are responsible for the changes we interpret with ultrasound. So cortical atrophy results in decrease in renal size, like I said, thinning of the parenchyma, particularly the cortex, and increased echogenicity of the cortex. And when this is happening, it's a reflection of fibrosis and sclerosis. Why fibrosis? When a kidney is diseased, we do have some cells of the kidney that end up dying. Let's say maybe it's chronic inflammation, which is uncontrolled. Some of the cells in the end will die. And when they die, they are replaced with fibrous tissue, or they undergo sclerosis. So now, because fibrous tissue is an attenuator or a higher attenuator of sound, the kidney will start to change its echo pattern to become more and more hyperechoic from the initial hypoechoic echo pattern that we know. Okay, so papillary necrosis, it refers to ischemic necrosis of the medullary pyramids. Remember, I've shown you the various pyramids that form the medulla, right? And now, inside each pyramid, the medullary pyramids are the ones that link to the narrow portion. Their narrow portion is called the what? Papilla. And the narrow portion of the pyramid links to the minor calyx. And inside is the filtration apparatus, right? So the filtration apparatus, it links between the cortex and the medullary papilla, in the medulla, or it's within the medullary pyramid. So it's from cortex to medullary pyramids into papillae, calyces, and out, right? So this necrosis of the medullary pyramids and papilla, it causes sloughing of tissue, causing a substantial loss of renal function. So whatever disease it is there within your kidney, it may make your kidney undergo this process that I've indicated on my first bullet. So the renal medulla and papilla are susceptible to ischemic necrosis due to their blood supply and hypertonic environment. So we may in the end have a calyceal and ureter obstruction by sloughed papillae, and this manifests as flank pain. It may also manifest as hematuria and varying degrees of renal impairment. The patient may experience what we call anuria or oliguria. Anuria is when the patient is producing a volume of urine which is less than 50 milliliters, and oliguria may be less than 250 milliliters of urine. This may be present in the fulminant stage if renal failure develops. So now, because the patient is experiencing this obstruction of their calyces or obstruction of their ureters, we will have a situation of urinal stasis, like the urine that is produced will in the end not be able to drain easily outside the kidney. So So now urinary stasis leads to pyelonephritis or inflammation of the kidney, and the patient may experience fever, chills, and they may experience rigors.
Even bit.
Okay.
I knew.
Sorry, I think some people need to mute their mics. Okay, thank you very much. So now when the patient is experiencing urinary stasis, it leads to pyelonephritis, like I've said, and the patient can be producing blood urine, right? The urine can be cloudy, all right, or it can be dark urine. In my experience, I had a patient who thought that they were urinating sperms because of this condition. Papillary necrosis can be incidental finding in asymptomatic patients, but it can also be severe and present as a life-threatening condition. Right. Now, let's look at the causes or risk factors for nephropathy. So like I said, nephropathy is when the kidney is diseased. And if nephropathy is chronic, the patient experiences renal failure. And if you are experiencing renal failure, then it necessitates that you need to be done a renal dialysis, or if it's too severe, then it means a kidney transplant may need to be done for you. So let's look at the risk factors that may make you to experience nephropathy or disease of your kidneys. One, it can be poorly controlled or chronic hypertension, high blood pressure. We also have poor glycemic control in type 1 or type 2 diabetes. We may have glomerulonephritis, which is uncontrolled, pyelonephritis, like I just explained, polycystic kidney disease. If your kidney, the tubules are inundated with a multiple cyst, it may result in a reduction of renal function. Then we also have a scenario whereby if someone ingests or they overdose on medications or analgesic nephropathy, right? You know, analgesic medications like ibuprofen, you know, if they are taken to, like if someone is overdosing on them, they can actually cause a nephropathy. So we need to be careful as well. Even if we are ingesting too many antibiotics, it can make us to experience nephropathy. Then another one is nephrolithiasis, or the formation of stones in our kidneys, HIV, COVID-19, tuberculosis. So these are the few that I managed to just pinpoint. So all these causes of risk of nephropathy can result in renal failure. And when as end stage, if chronic, this therefore necessitates for renal dialysis. So if this your renal failure is now end stage or the final stage of renal failure, you may need to undergo renal dialysis. Okay, now I'm going to be picking one pathological condition, talk about it a little bit, show you the B-mode sonographic appearance, right? But remember, all these appearances that we are going to see on these kidneys, it is because this underlying condition is either making the kidney to undergo cortical atrophy, or, and then there's also the presence of fibrous tissue, or there is papillary necrosis, or they are stones, right? So with renal calculi, the crystals of salts present in urine occasionally, and the crystals of salts present in urine, they occasionally precipitate and solidify into insoluble stones called renal calculi. Commonly, the crystals, they contain crystals of calcium oxalate, uric acid, or calcium phosphate. Conditions leading to calculus formation include ingestion of excessive calcium, low water intake, abnormally alkaline or acidic urine, and overactivity of the parathyroid glands. Why the parathyroid glands? Because their main job, they regulate the levels of calcium in the blood by either activating the osteoclastic or osteoblastic activity of our bones. If it's osteoclastic activity, the bones will undergo this kind of process and release calcium, okay? And osteoblastic activity does the opposite, right? So now when your parathyroid glands are overactive, it can result in you having excessive calcium in your blood. So when a stone lodges in a narrow passage, such as a ureter, the pain can be intense and you can present with what maybe sometimes with flank pain. Okay, so this is an example of what we see on sonar of nephrolithiasis. These are stones, right? Actually within the pyramids of this patient. Okay, now sometimes we can have, this can result in what we call hydronephrosis. In this situation, we can see that, okay, maybe this could have been maybe papillary necrosis, and all the rubbish or the slough of tissue come and gather in the narrow portion of the ureter. And in the end, as much as the apparatus are sieving or filtering the urine, producing urine, the urine is not draining out. We end up having such an obstruction. Now you can see that the renal pelvis, we can see it now. You can see the proximal ureter, but under normal circumstances, this will just be the white part of the kidney. Okay. And outside, this is our renal. Okay. Now, the next one I was pinpointing is pyelonephritis. Okay, I said this is inflammation of the kidneys due to presence of microbes, mostly sometimes retrograde introduction from the urethra. So let's say, for example, a patient is experiencing maybe we can give an example of a male patient. When male patients are aging, let's say around the 60s, the prostate tends to tends to hypertrophy, especially the transitional zone. Now, within the transitional zone, we have the urethra passing out, the urethra that drains the bladder and the urine to come out of the body. Now, when the transitional zone is hypertrophic, it compresses the urethra and the patient is not able to urinate. Sometimes the urine will come out, but they will, in the end, be leaving a reservoir of urine. So this urine stasis is not good. So bacteria now will tend to now travel from this urine, which is urine which is not leaving the bladder. It can travel retrogradely back via the ureters, and the patient can experience ureteritis and back into the kidneys, and the patient can experience pyelonephritis. Sometimes the blockage may be severe, so that the urine from the bladder may start to reflux back into the ureters and into the kidneys because the bladder is overfilled. And this now introduces infection to the kidneys. So this is another way we can have pyelonephritis, or the other one whereby, right, if the sloughing of tissue tends to block the minor or major calyces, urine stasis again will make the patient to experience pyelonephritis. So if pyelonephritis becomes chronic, scar tissue can form in the kidneys. Like I said, we have scar tissue forming because the cells, some of the cells would have died and they are replaced with scar tissue. So this can form in the kidneys and can severely impair their function. So the echo pattern of the kidney now transites from its normal hypoechoic due to swelling with inflammatory exudate in the acute phase, and then it goes from the hypoechoic phase to hyperechoic due to presence of scar tissue and papillary necrosis in the chronic phase. Right. So it's an example of pyelonephritis. This is now chronic pyelonephritis. Look, the kidney would have reduced in size. It has become more hyperechoic. Now you see a striking difference between the medulla, these are the pyramids, and the cortex, right? Why they are prominent? It is because there's blockage of the minor calyces as well, because of the sloughing tissue of the papilla and the pyramids. Now, the next one is glomerulonephritis. This is inflammation of the kidney that involves the glomeruli. You remember that filtration apparatus that I've just shown you before. So one of the most common causes is an allergic reaction to the toxins produced by streptococcal bacteria that have recently infected another part of the body. Let's say maybe throat, patient is experiencing throat infection, but they end up experiencing flank pain, and they may end up producing urine with blood. So why? Because the glomeruli become so inflamed, they become swollen and engorged with blood, that the filtration membranes now will, in the end, when they are swollen, they will allow blood cells and plasma proteins to enter the filtrate. Under normal circumstances, we don't expect to see blood cells or plasma or proteins to come out of the plasma from that filtration apparatus. But because of inflammation, red blood cells and plasma proteins will enter the urine. So as a result, the urine of the patient will be containing many erythrocytes or red blood cells, and it will present as hematuria, and there will be a lot of protein in the patient's urine, or what we call proteinuria. So this is an example of glomerulonephritis. So like I said, you find out that the filtration apparatus, which we call the nephron, the glomerulus or the corpuscle is within the cortex, right? And then now the tubules, you find them within the medulla or within the pyramids, right? So because these ones are within the cortex, when they are swollen, there is inflammation, and the inflammatory exudate, we expect this part to be darker than normal, right? It is dark because of inflammatory exudate, okay? And now you also see now this urine within the pyramids, it is prominent because of the mild blockages of the minor calyces. Now, the next condition, diabetes, right? We can refer to this as diabetic nephropathy or diabetic kidney disease. It's a disorder caused by diabetes mellitus, in which the glomeruli are damaged, right? Because when it's uncontrolled, poor glycemic control, it means the patient, the urine will be containing a lot of glucose. And this makes the environment to be hypertonic and may cause the papilla to slough off, right? And the result now, when the glomeruli are damaged as well, we have leakage of proteins into the urine of the patient, and also a reduction in the ability of the kidney to remove water and waste. Okay, so you can see this an example of a diabetic kidney. Look, we are still in the maybe moderate stage. Look, the prominent pyramids with the urine, because of the sloughing off that is happening of the medullary pyramid and the papilla. Later on, if it continues chronic, the kidney is going to change its size and also becomes more hyperechoic. The next condition we're going to look at is polycystic kidney disease, right? So in polycystic kidney disease, it's an inherited disorder, and the kidney tubules become riddled with hundreds of or thousands of cysts. So in addition, there'll be the inappropriate apoptosis or programmed cell death. So here, the cells in the non-cystic tubules will start to undergo progressive impairment. They undergo death, and this results in progressive impairment of renal function and eventually leads to end-stage renal failure. Sometimes such patients with polycystic kidney disease, they may have cysts developing in other organs, like in their liver, in their pancreas, in their spleen, and here it becomes called what? Multiple cystic kidney disease, right? So this one, typically the symptoms are not noticed until adulthood, when patients may present with back pain, urinary tract infections, hematuria, hypertension, and large abdominal masses. So however, the treatment of hypertension, restriction of protein and salt in the diet, controlling urinary tract infections may slow the progression to renal failure. Okay, so this is what we saw sonographically, a polycystic kidney disease. Look, the echogenicity of the kidney is actually changing. It's becoming more hyperechoic. Now, renal failure. So all the conditions I've listed, if they are not controlled chronically, it results in renal failure. So renal failure it refers to a decrease or cessation of glomerular filtration. And in acute renal failure, the kidneys abruptly stop working entirely or almost entirely. It results in oliguria, like I said, a daily urine output between 50 to 250 milliliters, or anuria, whereby the daily urine output is less than 50 milliliters. So this can be due to low blood volume in hemorrhage, decreased cardiac output, or the conditions which I've given you: damaged renal tubules, kidney stones, like I've said, non-steroidal anti-inflammatory drugs, some antibiotic drugs, contrast media, or the list that I've given you of those conditions. All right. So complications of renal failure: patient may experience edema due to salt and water retention. Patient may present with metabolic acidosis due to an inability of the kidneys to excrete acidic substances. The patient can also experience what we call uremia, or toxic amounts of urine in the blood, or urine substances within the blood. For example, we've got urea. This is one of the examples: loss of nitrogen substances within their blood. The patient can experience hyperkalemia, or hyperkalemia, it means abnormal or elevated amount of potassium in their blood. But this is supposed to be excreted within the apparatus when everything is well. All right. Patient may also present with anemia due to insufficient erythropoietin for adequate red blood cell production. Why? Because the kidney is damaged. Its other job is to produce erythropoietin, which enables the production of red blood cells. Again, the patient may present to us with osteomalacia. Why? Because now the kidney is failing to convert vitamin D to calcitriol, which is needed for adequate calcium absorption from our small intestines. Right. Now, chronic renal failure will present in 3 stages, right? So it is progressive and usually irreversible decline in GFR. What you call GFR, this is glomerular filtration rate. So now, for someone to be in chronic renal failure, they will be having a progressive and irreversible decline in GFR, and this results from either chronic glomerulonephritis, like I said, pyelonephritis, polycystic kidney disease, TB, HIV, traumatic loss of kidney tissue, and then we also have these medications, like I said. So in the first stage, we have a diminished renal reserve, and we've got about 75% of the nephrons for the filtration apparatus, the one that I've shown you, they would have been destroyed about 75%, right? But however, these stages are symptomatic, because now, even if 75% is lost, the remaining 25% nephrons tend to undergo what you call hypertrophic compensation, so that they are trying to take over the workload, which is now supposed to be done. Now, but in the second stage, the patient will enter what you call renal insufficiency, whereby they experience further decrease in GFR and increased uremia, and also reduced creatinine clearance. Now, the end stage, that's why we know such patients, the doctor will say, all right, go for sauna, you must do U and E. U and E stands for urea and creatinine. Urea and creatinine levels in their blood will indicate also to the referring clinician the degree of renal impairment that the patient is experiencing. Now, in the end stage, about 90% of the nephrons have been lost. The GFR diminishes to 10 to 15%. You see, GFR is always written on when the patient undergoes this laboratory test. They also indicate the GFR of the patient. So now the patient would have the GFR would have diminished to 10 to 15%. And normally we see oliguria in the patient. The patient will be having uremia. So the blood test of the patient will indicate that the patient has got uremia, the patient has got hyperkalemia, and then we have got reduced GFR. So such patients now need dialysis therapy or kidney transplant. Okay, this is an example of the kidney that we see in chronic renal failure patients. Now, we can also look at the stages. This is stage 1. You may start to these kidneys are either isoechoic, mildly hyperechoic. Look, they're transiting to this stage, and here there is a reduced corticomedullary differentiation. You can't see a difference between the two. Right, what is renal dialysis? Now, renal dialysis, this is a treatment needed when kidneys develop end-stage failure, and about 85% of the kidney function is lost, resulting in the GFR less than 15. And dialysis is achieved 2 ways. As either it can be done through what we call hemodialysis, when fistulas are surgically created between native vein or artery and pumped out of the body to an artificial kidney machine and returned to the body by tubes that connect vessels to the machine. Then the other way it can be performed, it is achieved through what we call peritoneal dialysis. When the peritoneum is used as a natural filter, wastes are taken out by means of a cleansing fluid, which is called the dialysate, which is washed in and out of the belly in cycles. So I've got, so dialysis is a process of removing excess water, solutes, and toxins from the blood in people whose kidneys can no longer perform these functions naturally, and this is referred to as renal replacement therapy. Okay, so this is an example of a patient when they are connected to the dialysis machine. This is an example of hemodialysis, and this one is an example of peritoneal dialysis. Okay, so generally, the role of ultrasound in hemodialysis, most of the time we don't really need ultrasound for guidance when we are performing catheterization of central veins, but it is now considered the standard of care, and when it's done with ultrasound guidance, the success rates are also higher and less complications. So the site should be imaged before the procedure to ensure normal anatomy is seen and adequate visualization of the target. And mostly we talk of the internal jugular vein, which we see lateral to the carotid arteries. We have the common femoral vein, which is medial to the common femoral artery. In others, they utilize the brachiocephalic vein or artery by the elbow, just by the elbow. So sites of previous catheterization or attempt should be examined for venous thrombosis or arterial pseudoaneurysms, and the internal jugular vein should be imaged down to the subclavian vein to confirm patency. Okay. Right. So I think I needed to tackle. Sorry, there's someone talking in the background. Please kindly mute your mic.
Mr. Gibson, Mr. Gibson, may you kindly mute your mic, please? Thank you.
Okay, so now duplex ultrasound imaging. When we say duplex, popularly we say duplex, but I think what we now have is triplex. When we say triplex ultrasound imaging, it is because we're utilizing B-mode imaging or grayscale imaging. We're utilizing Doppler, which can be color, power, or pulse Doppler, and we are also utilizing color Doppler, color Doppler. All right. So in B-mode or grayscale imaging, the returning echo, we usually assess it for its amplitude or strength or brightness, or its go return time. So when we say amplitude or strength, like when you shoot the sonar beam in the patient, what we record are the returning echoes, because the sonar beam will enter the patient and the beam is reflected at the various depths of the patient's body, right? So depending on the depth to which each sonar beam would have hit, it will be returned like go return time. So if it's superficially, it's quickly returned back to the monitor of our sonar machine and it's located superficially. And if it's taking a longer time to return, it will be located more deeper. This is how we are able to interpret the anatomy. So the anatomy that we see on the sonar monitor are the echoes of various amplitudes or echoes of various strengths or echoes of various brightness, which are located according to their return times on the sonar monitor. And this is what you print out on your thermal paper, right? But in Doppler imaging, we've got a third parameter, which is called frequency, which is assessed in the returning echo, right? But for you to understand this Doppler, I thought I could swipe a bit. I don't know if I still have got enough time. This is 8 o'clock. Miss Convener, please.
I'm sure you can go on, Dr. Tityiwe.
Thank you very much. Please make sure that you are sipping some tea so that you are not sleeping, right? I need to share a little bit on Doppler effect so that when I'm showing you the images on Doppler, they will make sense, okay? So Doppler effect, what is Doppler effect? So in B-mode imaging is what I've explained, that you are now seeing the echoes of various amplitude or various brightnesses, and these are located according to their the go return time, which the sonar wave would have experienced at each and every stage, right? But in Doppler, what is happening is we are imaging the blood, right? And the blood is flowing. So in the B-mode imaging, the reflector or the target is stationary. Obviously, your body is not moving. So when you shoot your first frequency into the frequency of the sonar beam in the patient, it will come back. The echo will return with the same frequency. It doesn't change. So let's say 5 megahertz, come back 5 megahertz in the echo. But in the Doppler, when I shoot my 5 megahertz, the returning frequency of the echo is different from the one that I would have shot in. Why? Because the reflector or the target is moving. What is our target in flowing blood? These are blood cells, mostly red blood cells. So let's say I shoot initially at a red blood cell that is at point A, and it is blood in the artery, which is flowing away from my probe or from the heart. So if I start it at point A, by the time the echo returns to me, it will be here, further away from here where I am. I'll be able to see an echo of longer wavelengths, right? Longer wavelengths and reduce the frequency, right? But if I'm shooting it here, here, and it's blood moving towards my probe or towards the heart, which is venous, this is going to be shorter wavelength frequency. So which means in arteries, initially from my transmitted frequency, the returning frequency would be different, right? It will be increased, but in the vein, it will be reduced. That's why you see the waveforms of the vein, they are closer to each other, right? But in the artery, far from each other, and the wavelengths are deeper in the artery and more smaller in the vein. I will show you the waveforms later. So now this change in frequency between the initially transmitted frequency to the one that is produced by the returning echo is what we call Doppler shift frequency. And this is what we call Doppler effect. So this is, it comes out, or it comes out as elicited sound in the audible range, which is 20 hertz to 20 kilohertz. This is why on our machine, because we've got these stereos and the speakers, we are able to make the sound loud enough for us to hear. That's why we hear this sound, or if it is a very, right? We continue. Now, why? Because we are utilizing what is called the Doppler equation. Me, I didn't do physics. So here, I'm explaining the Doppler equation in the simplest way. Even someone who has never done physics will understand, right? Here is our Doppler equation. FG means Doppler shift equals to 2 times transmitted frequency times the velocity of blood times the cosine of theta over C, right? C is the velocity of blood. Sorry, can someone mute their mic, please, in the background? Right. So Doppler shift frequency, or the Doppler effect, or what we see as the waveform, it is directly proportional to everything that is above the graph and indirectly proportional to this. But this is the sound of sound. It is a constant. So we want to consider this one, 1.54 meters per second, right? But when you go up here, the most effective parameter is cosine theta, right? Okay, fine. We may talk about the velocity of the blood, all right? The transmitted frequency, or the frequency of the sonar beam that I'm shooting in the patient. But what is most important is cosine theta. This is cosine of the Doppler angle. I'll show you later. Now, the Doppler angle, or the angle at which you are insonating your sonar beam into the flowing blood, it is very important, right? Now, if you know mathematically, we all did the method from form 1 up to 4, 5, whatever. Cosine theta refers to the cosine of the Doppler angle. So if cosine of 0, we have 1. If you can use your calculator, just put cos 0, you see that it comes a 1. Cos of 60 degrees is a 0.5. Cos of 90 degrees, we find 0 Doppler shifts. So unlike in beam mode imaging, for us to get maximum or a good image, we need to scan at right angles, isn't it? Right. But in Doppler, it is the opposite. If you scan a blood vessel at 90 degrees, you get a 0 Doppler shifts. You don't see a waveform coming. So in the end, you say, this kidney is not perfused. Why? No, it is because of your wrong scanning technique. So your Doppler angle must always be between 0 and 60. I know 0 is unachievable because blood vessels are not like steel pipes, but we must be 60 and below. Okay. Now, so Doppler shift, we say, is directly proportional to transmitted frequency, velocity of blood, and Doppler angle, which is the one, but the speed of sound, I said, is a constant. All right. So arterial hemodynamics. So now this is the formula that you are using. For us to have blood flow in a normal setup of your body, right? Blood flow volume, it is pressure gradient over resistance, right? That's blood flows if pressure gradient exceeds resistance to flow, right? So the primary pressure to the blood is from the cyclic pumping of the heart, and it brings the pulsations that we feel in the arterial blood flow. Like if you put your hand on your wrist, you feel some pulsations, because they are coming from the cyclic pumping of your heart, right? So during systole, arterial blood pressure in large arteries will be about 120 millimeters of mercury. During diastole, blood pressure in large arteries is about 80 millimeters of mercury. And in capillaries downstream, it's about 10. Okay. So large pressure gradient between systole and diastole results in antegrade flow or forward flow of blood. Forward flow from the heart, forward flow in your arteries until it reaches to your capillaries and your arterioles and capillaries and perfusing your organs, right? So now this antegrade flow is toward the capillaries, and in large arteries, the peak systolic velocity is about 100 centimeters per second. This is the maximum velocity in the blood after it has been given the pumping action by the heart, right? So large arteries have got more elastic tissue, while peripheral arteries, they've got more muscular tissue and less elastic tissues. So large arteries stretch during systole and the recurve during diastole of the heart, which what we call Wind-Kessel effect. So now, in diastole, when the heart is relaxed, the elastic recurve of the large arteries provides blood pressure for antegrade flow. So as long as there's not too much resistance, the blood will flow, right? So during systole, the ventricles are contracting, blood moves and reaches the maximum velocity, which we call the peak systolic velocity, right? Now, when the ventricles are relaxing, right, the pump that is now working is the elastic recurve of the large arteries, which is the aorta and the pulmonary arteries, right? When they recurve during diastole, then that force makes blood to travel again forward, but at a lower level than the initial. So the peak of during systole and the peak during diastole is different. I want you to take note of this, because then you'll be able to interpret the waveforms that you see when you are performing Doppler. So the systolic pump is stronger and causes antegrade flow, even in the presence of very high resistance, right? Unlike the weaker diastolic pump, right? So with the Poisson-Lewis law, antegrade flow is reduced or absent during diastole when there is high resistance, right? So how can we have this high resistance coming? Sometimes when the vessel radius is reduced. Why? You are aging, plaque is forming inside the lumen of your arteries and reduces the radius of your arteries. Then the patient is having, I'm having high blood pressure. Oh, and the flow of blood is going to be affected, right? Viscosity of blood, length of the vessel, but mostly it is the change in pressure gradient and the vessel radius. So that flow volume is affected by change in pressure gradient and vessel radius directly, while the length of the vessel and the viscosity of blood, these ones are just constants. Right. Now, low, high, or very high resistant beds are determined by the arterioles lying between arteries and capillaries. So when you look at the vascular system, from the arteries, you go to arterioles, you go to capillaries. From capillaries, you go to what? Venules and veins, right? So arterioles are like the gatekeepers that make an organ to be either low resistant bed or high resistant bed, because arterioles can vasodilate or vasoconstrict, so they are the gatekeepers, right? So low resistant beds have dilated arterioles, high antegrade flow in systole and diastole. So for example, your brain or your kidneys, when they are normal, when your kidneys are normal, they are supposed to be low resistance bed, right? So now I'm just zeroing on these kidneys. But when your kidneys are diseased, right, with nephropathy or with renal failure, they become high resistance bed. Okay, please take note of that. So arterioles are more constricted in high resistance bed. The arterioles are more constricted. There is only good antegrade flow in systole due to high pressure gradients, but in early diastole, when the heart is relaxed and elastic recoil is not yet quite started, there will be a significant drop in forward flow, right? So in later diastole, when the elastic recoil sets in, there will be antegrade flow, though a reduced one. So this now gives you what we call a triphasic waveform, which consists of systole, early retrograde diastole, then later antegrade diastole. And these are reflected by high resistance beds. These are the waveforms that you see when you are scanning your femoral arteries of the legs, you know. But for the kidneys, if you started to see this kind of waveform, triphasic, it means, hey, nephropathy, and you are moving towards renal failure. So like I said, examples for high resistance beds, we've got a fasting gut, small and large bowel, non-active ovaries, non-gravid uterus, smaller muscular beds, and nephropathy in chronic renal failure. Now, I hope now with these basics, you can understand what we have. This is a normal kidney. When you put color, you see it's highly perfused. And when you bring your case up for assessing pulse Doppler here you are just assessing. If you can assess either the renal artery, you can assess the segmental, and it doesn't matter as long as you manage your sample volume size. So after this, and you see this is the kind of waveform that we see. This is a low resistance waveform. Why? From our system, when the heart is pumping and contracting, now when the ventricles are relaxing, right, we still have the elastic recoil managing to give us good enough amount of blood during diastole. So this is a what? Diphasic waveform. And now when you go on a machine, you start to measure. Put your cursor on the peak systolic peak of the waveform, and at the lowermost part of diastole. Most machines, the moment you do like this, they automatically calculate these parameters for you. Some will trace, some are automatic, and they will show you PS, which is peak systolic velocity, 30.9 centimeters per second. ED and diastolic velocity, 10.3 centimeters per second. RI, or resistive index. We utilize a parameter called resistive index to assess the degree of resistance that the blood is experiencing when perfusing through your kidney or any other organ. So you find that generally, according to literature and systematic reviews, when we see resistive index of 0.7 and below, it is normal. But 0.7 and above, now this is increased resistance. Now the kidney is starting to be what? High resistance bed. Okay, so this is the kind of waveform that you see in normal low resistance bed. And you see a resistance index, which is this one is 0.67. Right. Now look at this example. This is a high resistance waveform, right? Look at our kidney. Look at the waveform, right? Sharp peak systolic velocity, but we have got a small this drop during early diastole. Sometimes it can be reversed. Look at this. Actually, reverse, small amount of reverse flow. This is between systole to diastole, or between that's the Wind-Kessel effect. Wind-Kessel effect is starting here, but the moment it's starting to take over from systole, there is this drop. Why? Because there is increased resistance in this bed of the kidney. All right, fine. Even as the Wind-Kessel effect is starting to come in, you see the flow during diastole is low. It's not as high as up to here. Right. And our resistive index, RI, is what? 0.8. So this is a typical high resistance waveform, abnormal renal artery. This could be signaling either stenosis of the renal artery when it becomes stenosed when there's uncontrolled blood pressure, mostly chronic hypertension, poor glycemic control, the kidney is experiencing chronic nephropathy. Okay, so this is a waveform. We show that this kidney is not all right. All right. Now, this one is just showing you another utility of Doppler when we are checking the fistulas for dialysis, right? This one is triphasic waveform in the fistula. Why? Because this fistula is thrombosed. Now you see peak systolic velocity. Here we have got this retrograde flow and a small antegrade flow in diastole. This is showing that there is thrombosing of the artery, brachial artery by the elbow, just above the elbow, and there is stenosis. All right. Now here, this is brachiocephalic fistula, or this is a vein. The color is showing you that it's here, but the color is not passing through because there's a blockage with this whole thing from here to there is the vessel. This is thrombus within the fistula. Okay, we are coming to the end. We also utilize our B-mode imaging to assess. I said that we assess the sites for fistula. Can you see that these sites of fistula, they are thrombus? We can see this thrombus in B-mode imaging. If it's under normal circumstances, we must see a clear flow of blood, not these rubbish things that we see inside the fistula. Okay, ladies and gentlemen, thank you very much. I will send you the slide with my references. There were actually a lot of them. Otherwise, I've come to the end of my presentation and I leave this time to the convener. Thank you very much.
Thank you so much, Dr. T. Thank you so much for such a